Hello, friends. Today we are going to discuss American College of Gastroenterology guidelines on the management of acute pancreatitis, which are published recently. So, key concept is according to guideline, they have suggested early and at admission, routine computed tomography not to be performed for the purpose of determining severity in acute pancreatitis and should be reserved for patients in whom diagnosis is unclear or who fail to improve clinically within first 48 to 72 hours after hospital admission and intravenous hydration. So, regarding etiology of acute pancreatitis, we suggest the transabdominal ultrasound in patient with acute pancreatitis to evaluate for biliary pancreatitis and repeat ultrasound if initial examination is inconclusive. So, it has a conditional recommendation and very low quality of evidence. In patient with idiopathic acute pancreatitis, we recommended additional diagnostic evaluation with repeat abdominal ultrasound, MRI, and or endoscopic ultrasound. It also has conditional recommendation and very low quality of evidence. And the key concepts are in the absence of gallstone or significant history of alcohol use, serum triglyceride should be obtained and considered as the etiology, preferably if greater than 1000. In patients older than 40 years in whom etiology is not established, pancreatic tumor should be considered as possible cause of acute pancreatitis. Following second episode of acute pancreatitis with no identifiable cause in patient fit for surgery, guidelines suggest performing cholecystectomy to reduce the risk of recurrent episodes of acute pancreatitis. Now, regarding initial assessment and risk stratification, hemodynamic status and risk assessment should be performed to stratify patient into high risk and low risk categories to assist the consideration of admission to non-monitored bed or monitored bed setting, including intensive care unit. So patient with organ failure and SIRS should preferably be admitted to monitored bed setting. Scoring system and imaging alone are not accurate in determining which patient with acute pancreatitis will develop moderately severe and severe acute pancreatitis. In patients with mild disease, clinicians should remain vigilant for the development of severe disease and organ failure during initial 48 hours from the admission. So the risk factors of the development of severe disease include elevated blood urea nitrogen, hematocrit, the presence of obesity, comorbidities, and the presence of SIRS. Now, these are the clinical findings associated with the severe course for initial risk assessment. Now, patient characteristic, age more than 55, BMI more than 30, altered mental status, and comorbid disease. Then the presence of SIRS, which is defined by the presence of more than two of the following criteria, that is pulse rate more than 90, respiratory rate more than 20, PaCO2 more than less than 32, temperature more than 38 degrees Celsius or more than 36 degrees Celsius, WBC count more than 12,000 or less than 4,000, then more than 10% immature neutrophils. Then regarding lab finding, BUN more than 20, rising BUN, HCT more than 44, rising HCT, and elevated creatinine. Then regarding radiological finding, pleural effusion, pulmonary infiltrate, multiple or extensive extrahepatic, extrapancreatic collection. Regarding initial management, the recommendations are guidelines suggest moderately aggressive fluid resuscitation for patient with acute pancreatitis. Additional bolus will be needed if there is evidence of hypovolemia. So guidelines also suggest using the Ringer lactate solution over normal saline for intravenous resuscitation in acute pancreatitis. So guidelines also suggest all patients with acute pancreatitis receive moderately aggressive intravenous hydration of isotonic crystalloid. Caution is needed if cardiovascular and renal comorbidity exist. Patients should be monitored for volume over. Fluid resuscitation in patient with acute pancreatitis is likely more important early in the course of disease, that is within the first 24 hours. Fluid volume need to be reassessed at frequent interval within 6 hours of presentation and for next 24 to 48 hours with goal to decrease the blood urea nitrogen. So this is the diagrammatic representation of pancreatitis and demonstration of the effect with moderately aggressive intravenous hydration. So this is the normal pancreatitis, and in the first picture is demonstrating normal pancreas, and in second picture when the patient is having edematous pancreatitis, so there will be the fluid extravasation into the peritoneum. Because of this there will be the increased intravascular fluid loss and decreased intravascular volume. So because of that there will be the manifestations like rising hematocrit, rising blood urea nitrogen, and decreased blood flow to the pancreas, and the pancreas will show some ischemic changes due to decreased perfusion. So when so during this phase, if we will moderately aggressive, if we'll perform the moderately aggressive intravenous hydration, then this condition we can reverse and prevent it from going to the necrotizing pancreatitis. Then the ERCP in acute pancreatitis guidelines suggest the medical therapy over early ERCP in acute biliary pancreatitis without cholangitis. It has conditional recommendation and very low quality of evidence. In patients with acute pancreatitis complicated by cholangitis, early ERCP within first 24 hours has been shown to decrease morbidity and mortality. In the absence of cholangitis and jaundice, if CVD stone is suspected, MRCP or endoscopic ultrasound should be used to screen for the presence of CVD stone before the use of ERCP, and diagnostic ERCP should be avoided. Now, preventing post-ERCP pancreatitis. Guidelines recommended rectal endomethacin to prevent post-ERCP pancreatitis in individual considered to be at high risk of post-ERCP pancreatitis. We suggest placement of the pancreatic duct stent in patient at high risk for post-ERCP pancreatitis who are receiving rectal endomethacin. So the first statement has strong recommendation and moderate quality evidence, and the second statement has conditional recommendation with low quality evidence. That is, the strong recommendation is for the statement of putting rectal endomethacin to prevent post ERCP pancreatitis in patients who are considered to be at high risk for post ERCP pancreatitis. Now, regarding the role of antibiotic, guidelines are against the prophylactic antibiotic in patients with severe acute pancreatitis. It has a very low quality of evidence, and the guidelines also suggest the fine needle aspiration in patients with suspected infected pancreatic necrosis. And while antibiotics should not be used in patients with sterile necrosis, antibiotics are important part of the treatment with infected necrosis along with debridement and necrosectomy. So in patients with infected necrosis, antibiotics are known to penetrate pancreatic necrosis, should be used largely to delay surgical, endoscopic and radiological drainage beyond 4 weeks. Some patients may avoid the drainage altogether because infection may completely resolve with antibiotics. Routine administration of antifungal along with prophylactic or therapeutic antibiotic is not needed. Regarding nutrition in acute pancreatitis, in patients with mild acute pancreatitis, we suggest early feeding within 24 to 48 hours as tolerated by patient compared with traditional nothing by mouth approach. This has conditional recommendation and low quality evidence. In patients with mild acute pancreatitis, we suggest initial oral feeding with low fat solid diet rather than stepwise liquid to solid approach. It also has conditional recommendation and low quality evidence. Enteral nutrition in patients with moderately severe or severe acute pancreatitis seem to prevent infectious complications. Parenteral nutrition should be avoided unless the enteral route is not possible, not tolerated, and not meeting the caloric needs. Using nasogastric rather than nasojejunal route for the delivery of enteral feeding is preferred because of comparable safety and efficacy. The role of surgery. In patients with mild acute biliary pancreatitis should undergo cholecystectomy early, preferably before discharge. Minimally invasive methods are preferred to open surgery for debridement and necrosectomy in stable patients with symptomatic pancreatic necrosectomy. We suggest delaying any intervention that is surgical, radiological, and endoscopic in stable patient with pancreatic necrosis, preferably 4 weeks to allow for wall of collection to mature. This is the diagrammatic representation of management of the pancreas. If you're suspecting pancreatic necrosis, typically after 7 to 10 days, that means if it is characterized by the new onset pain, fever, and SIRS, then we can skip the CT aspiration. Assume that it is a assume it is an infected necrosis, and we should start targeted antimicrobial therapy which will help in penetration. And now they divide the patient into two categories, that is clinically stable and clinically unstable. If the patient is clinically unstable, then the prompt surgical debridement is needed. If the patient is clinically stable, then continue antibiotic and observe, delay minimal invasive surgical, radiological, endoscopic debridement for 4 to 6 weeks. And in select patient who do well, no debridement. Thank you.